Dear urologists, good evening one and all. As you all know, Pure Urology has reached 8,000 members now, and it is one of the largest Facebook group. A lot of the seniors have consented for expertise talk in the Pure forum. In the coming 1-2 months, we have already booked the slots. Let us hope the juniors, friends, and the seniors will contribute and learn and teach through this forum urology. Today, actually, it is a different topic, even though it is not surgical technique. As you all know, the role of ultrasound is beyond doubt proven in not only renal stone management but various other aspects like prostate biopsy, kidney biopsy, doing even bedside ultrasound. When we used to do PCN ultrasound guided, that was the only procedure, and it used to be semi blind. Last part of the needle, we don't know where it is going. If the water comes, if the urine comes, we are happy, or else we will be doing in another direction. It is not like that. Over the things have changed. Recently I have also brought BK ultrasound after a long waiting. Even routine ultrasound like Philips, we can do ultrasound some procedures, but anything which a trajectory, you can do better job. So there are various aspects like superficial part, herge, the deeper part like scrotum we see, varicocele we see, AV fistula we will see. There is a lot of role. In 1 hour we cannot cover this topic. That's why I have chosen Dr. Abhishek Singh, who has done lot of work on the BK ultrasound as well as the other ultrasounds also. And I requested him to teach the basics and how it is used, more so the buttons, the options like that, so that all of us can have this recording and practice whenever we take any ultrasound and then do accordingly. So briefly, Abhishek has already given one talk with us, so I will introduce him directly through the my PPT, and then I will hand over the program. Switch it off. What is it? I will hand over the program. So video based surgical presentation on basics of ultrasound and its applications by Dr. Abhishek Singh. He is the consultant urologist, Muljbhai Patel Urology Hospital, Nadiad, Gujarat. In Nadiad, Gujarat and Muljbhai Patel Hospital, lot of ultrasound usage is done at the bedside also, OPD side also, and in the theater also. They have plenty of ultrasound. That is the vision the institute had last 25 years. That's why he is the ideal candidate who is working day in and day out in the institute. He stood first in the university during MCH and first in the country during DNB. That itself speaks his academic caliber. He is council member, Youth Council of Urology Society of India, awarded HS Butt Gold Medal for the year 2013-14, member of editorial board of Indian Journal of Urology, 69 peer-reviewed publications, 17 book chapters and reviewer for 7 journals. DNB postgraduate teacher since 2019 after he joined as consultant at Muljbhai. Invited as faculty and presented 66 invited lectures during the COVID era. He actively participated in social activities involved in triage, primary and definitive management of victims of Mumbai terror attack in 2008. That is good, I didn't know this. Participated in surgical camps for tribals conducted by Rotary Club of Nagpur. Definitely a man with ambition, knowledge and hard work will never fail. He is one such person. Even though he is my junior, I have seen him last 2 years vibrant and doing lot of academic work mainly. So with that introduction of an excellent knowledge person, I will hand over Dr. Abhishek for the presentation of today talk, ultrasound basics and its applications. Thank you, Abhishek. Over to you. Take time, go slow. It is a documentary. Lot of people will see later on also. It is a lifelong YouTube link. Lifelong, the same link can be used for anybody through the YouTube. Thank you. Over to you, Abhishek.
Thank you very much, sir. Needless to say that your effort and commitment towards teaching and training is going to help everybody. It is not easy that every day at 5 o'clock you spare 1 hour out of your busy schedule. You are also running 3 major hospitals, which in itself are very, very high volume. So it is a sense of commitment that you have towards learning yourself and teaching others that is helping us go ahead with this program. So I thank you very much. for creating this platform, which is helping all of us learn more and more. And I also thank you for the invitation and kind introduction. Going ahead, today we will be talking about ultrasound for a urologist. Well, ultrasound, till I finished my residency, I thought it is a job of a urologist to read reports at best, and he need not know the basics of ultrasound. But as as is the rub of green with everybody who comes to MPUH, he gets enthralled by technology and the vision that Dr. Desai has for everybody. And his love for ultrasound goes down everybody's throat. That is how I started learning ultrasound. And at the end of these 8 years, I have realized that it is indeed a second opinion that everybody needs. I have nothing to disclose. Going ahead, I would be talking about the machine, use of ultrasound for kidney, gaining access to PCS, renal biopsies. Thereafter, discussing about transplants a little, going into trust and trust guided biopsy. And finally, discussing about unusual situations like using a drop down probe, using intracavitary ultrasound, talking about an obturator block, and eventually talking about ultrasound for vascular access. So let's get going. This is a sample of a few ultrasound machines that we have. The panel of the ultrasound machine will have some essential ingredients that for a startup are very important to know. So if you look at the panel here, you will see a zoom button, a home button, a B written boldly, a C written boldly. Then you would see a frequency diagram and these two parallel arrays. And then X dot 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 X measurement key. So this along with a trackball in the center. These are the essential ingredients of any ultrasound machine. So if you look at, we'll be describing a few different type of machines. And again, I want to disclose that this don't pertain to any particular company, but we have a little bit of exposure to BK. Therefore, these are BK machines that we are discussing. So if you see a convex probe, primarily this is a convex probe that we are trying to describe. Then this is a C button, which is basically to run the color Doppler. B will be for grayscale. And this particular frequency sign that you see will be for measurement of velocities and frequencies. Then at the left-hand corner, if you see, once you click that, you will be able to see what kind of probes are actually connected to the machine at this point in time. And when you click at that, so here 8818 is the truss probe that is connected. And adjacent to that, you can see S written, E written, or T written. That is the mode in which the probe is running. Just a bit of technical details. How do you change the probe? So this is the probe head, which goes into the socket and then you lock it. So this is the linear probe that we are showing here. Linear probe, the screen, you see linear arrays. In the convex probe, you see the convex arrays. So coming to another kind of a machine, here we are talking about a little advanced machine. So when you make the click, you can see the three probes are aligned together. Depending upon the capacity of the machine, it can take in one probe at a time, two probe at a time, or three or multiple probes. So here you see three probes are connected at a go, and there is a provision for the fourth probe. So four probes can be connected to this particular machine. Now, this is the linear probe that I was talking about. This linear probe or the convex probe both have a puncture attachment. Even the truss probe has a puncture attachment, which we will subsequently see. So this particular linear probe has a puncture attachment here, and the puncture attachment is specific to the machine. So it is critical that you use a particular puncture attachment or a biopsy guide of a particular probe for a successful surgical task to be accomplished. So when you are doing advanced scanning, there is when you require this C button or the color mode, the power Doppler, and these frequencies, which will help you detect the flow basically. When the subject or the organ is deeper situated, or you think that the amount of flow within the organ is less, that is the time you would use a power mode or a power Doppler, which will enhance the limited flow which is present. Typically, linear probe will be used for superficial structures like superficial vessels, which can be scanned for an AV fistula, a testis. Convex probe can be used for kidney, deeper situated organs, and truss probe is something like a variant of a vaginal probe and is used for transrectal ultrasound. A bit about attaching the biopsy guide or the puncture guide to a convex probe. So this is a convex probe which has a frequency of about 3.5 to 5. Now you see the groove which is meant for the puncture attachment. There is a projection which sits into the puncture attachment, and there are two rings. There are two rings. The one ring is exactly opposite to the freeze button and one is laterally placed. So once you connect, it is very, very important that you connect the puncture guide properly, because all the evaluation of the trajectory of the needle is dependent on perfect positioning of the puncture guide. If your puncture guide is angulated by 10 degrees, howsoever correct you puncture, the needle is never going to hit the target. Therefore, it is critical that you align the puncture guide perfectly. The trick to do this is that there are two wheels which will help you tighten the puncture guide on the probe. So the bigger wheel is opposite to the freeze button, and the smaller wheel is to tighten the groove through which the needle passes. So once you pass the needle, that is the time you balance the needle with your two fingers. So here I am putting the needle through the puncture guide and then balancing it with two fingers and then tightening the lateral screw. Depending upon how much freedom of movement I want, I should decide to tighten the lateral screw. So to do all upper tract.
I wanted to interrupt once here.
Yes, sir.
Abhishek, when you put this needle, I am using it now for last 3 months. When you probe is fixed towards one alignment in relation to the kidney calyx, when you put it, usually you cut the skin with a blade.
Yes, sir.
So when you cannot cut once you put it an angle and then you prick with the needle, then without cutting the skin it is very difficult. Normally
Yes,
any
sir.
PCNL you cut. So will you cut the skin and then start probing, or will you probe and then go with the needle?
Yes, sir. So that is a very pertinent question. What I would do is, I would take out the stillet of the needle. I would take the stillet of the needle out and let the trocar be there. Only the trocar be there. Now with everything in position, I would enact as if I was actually puncturing, and this will help me see the trajectory of the needle also. Now this will make a mark on the skin. It will make a circular impression on the screen. There is where I will put in a knife, make an incision. Now I'll put the stillet back and do the regular puncture. So that
The
is how.
respiratory movements make a little difference here. You should get back to that position where you have aligned the trajectory, isn't it?
Yes,
So
yes, sir.
yeah, that is important.
Yes. So, sir,
Okay.
it is also a function of how, if really the dilatation of the kidney is minimal, then you require deeper plane of anesthesia. When there is anything more than 7, 10, more than 10 mm of dilatation, there 1 or 2 millimeters will be forgiving. But the puncture movement has to be done within a fraction of a few seconds till the point the patient can hold his respiration in a particular way. So just briefly, let us understand the armamentarium of transrectal ultrasound here so that we will complete the basics of machine and then we can go on to the procedures. So this is a special probe because it is usually a biplanar or if required a triplanar probe. So if you imagine this to be the head of the transrectal ultrasound, it will have ability to scan at the tip, at the lateral portion, and at the neck. So this makes the probe triplanar. That means it can visualize in all 3 dimensions. It will have an ability to fire sideways. And if it is an end firing probe, it will have an ability to fire in an end-on direction. The frequency of a convex probe is anywhere between 3.5 to 5, and of a truss probe is 6 to 12 megahertz. As the frequency increases, the focal length decreases. So when you are doing intraluminal ultrasounds, you need higher frequency because you need a lower focal range. If you are doing a transcutaneous ultrasound, like if you are scanning an kidney, that is the time when you require frequency between 3.5 to 5 because you require a longer focal range. Skin to PCS distance, we know, is typically anywhere between 7 to 12 centimeters. So let us get on with the procedure. Any urologist who wants to learn ultrasound basically wants to learn it for an ultrasound guided puncture. And this is something that every urologist wants to achieve with precision because he wants to accomplish a very good PCNS. Needless to say, there can be situations where he doesn't have an option but to puncture the kidney using an ultrasound. PCN conventionally can be done by a fluoro method by puncturing the kidney blindly by using a needle passed perpendicular at the level of Grindfeld's triangle. Though this is an inconsistent method, but a very popular method. But imagine a situation where there is a ureteric leak, a ureteric injury. You have created an ileal conduit and now the ureters are leaking. Your gynecologist colleague has done an hysterectomy and the ureter is leaking, and many more such situations. These are the situations where you will have to do an ultrasound guided PCN. There is no option here. So let us see the technique of doing an ultrasound guided PCN. Scan the kidney, start scanning at the paraspinal location and come to the flank. At the area of around posterior axillary line, you will find a window to the kidney at 45 degrees. And thrust your needle through the pre-placed incision. And here you can see the needle entering the pelvic ileal system. So at this point, disengage the circular screw, get your ultrasound by the side. Hold the hub of the needle with a gauze piece and remove the needle pistillate out to see if you have punctured correctly or not. Subsequently, you can do a dye study and ensure that you have punctured the correct calyx or you have punctured the kidney or not. So just to repeat the steps, you use the probe perpendicular or longitudinal to the axis of the body. You start to scan in the paravertebral area. Keep moving your probe towards the posterior axillary line. At a point, you will visualize the kidney completely. Try to visualize the calyx in such a way that you can see the, the calyx itself, the infundibulum, and preferably the pelvis. If there is a pelvic stone, there should be a clear window visible from the calyx to the stone. That means your calyx is preferable. Let us demonstrate the same thing in a stone situation. So here we are managing a stone. Similarly, we have scanned. To the left of the screen is the cranial end, right is the caudal end. You have scanned. Now you are seeing the calyx and the stone in the pelvis. So this is the stone in the pelvis. So you should get a direct access from the calyx through the infundibulum to the stone. You can make a direct puncture, or you could use the hub technique as we discussed 2 slides before. So here we are, and till the patient is holding his respiration, it should happen within fraction of few seconds. Now we see the needle into the pelvic ileal system. Demonstrating the needle into the pelvic ileal system is important, but every time it may not be possible. Patient may be obese, dilatation may be limited. That is the time when, along with your ultrasound knowledge, it is very important to have the normal tactile feed that you would have while puncturing the pelvic ileal system. Here in this particular video, towards the end, we could also visualize the wire going into the pelvic ileal system. Another such example is a puncture with the all-seeing needle. So why I'm trying to demonstrate this particular video? Because here all the layers are also visualized. This was done by Desai sir, and all the layers can be visualized, as well as the movement of the needle in the ultrasound can be clearly seen. So here goes the needle ultrasonically, and also the structures will be visualized. So these are the layers which are seen, and now we are into the pelvic ileal system. So onto the right side of the screen, we could clearly see the needle getting into the pelvic ileal system on ultrasound, and we saw the same thing on the endo view as well. And we could also see the fat, the pericaliceal fat that was clearly visible. And then you put in the flexible scope in this particular case, and eventually the pelvic ileal system was visualized. So that is the pelvic ileal system visualized. So the single most common and the important use of an ultrasound to a urologist in operating room is gaining access to the pelvic ileal system. Another important indication of upper tract ultrasound is doing a renal biopsy. Renal biopsy, I agree, has a limited space as far as renal masses are concerned, but this space is growing. Also, there is a lot of ambiguity as you keep on dealing with different kinds of small renal masses and sometimes with metastatic disease. Situations like lymphomas, infections, these are the situations where you would definitely require a renal biopsy. So this is a biopsy gun by Bard. This is Magnum. And whenever you are doing a renal biopsy, there are 2 core lengths that are available, 22 millimeters and 15 millimeters. This is the fire button, and you have to clutch the biopsy gun twice so that the silver zone actually becomes red, and then charge the gun. You move this particular button to fire from standby. This gun is charged, and now we are ready to take a biopsy. Usually in renal biopsies, we would take 15 course, and in trus biopsies, you will take 22 course. The principle is same. Visualize the kidney, visualize the mass, get the mass in the center of your frame, give adequate local anesthesia, a stab incision is made. Like you would load your puncture needle, load the biopsy gun, let the biopsy needle pass the fascia, and then take your needle to the renal capsule, indent the capsule, and then fire. So once you indenting the capsule is very, very important. So there you can see the trajectory of the biopsy guide, and a very good core would subsequently come out. Again, the same situation, indent the needle, and then is the situation where you make a fire. You can clearly see the core that has come out here. A good trick is whenever you are doing renal biopsies, take the biopsy, let your pathologist see the biopsy, then only take the patient out of the table. After doing a few biopsies, you actually know what is fat and what is the actually renal tissue, but make sure that you get a good core of renal tissue. Now moving to situations where actually ultrasound may be of lot of help, because if you do a fluoro-guided puncture in this situation, there may be difficulties that are encountered. So let us discuss a situation of ectopic kidney where the ultrasound can be extremely useful. Do an ultrasound. If the pelvis is anterior and you do not see any silhouette of renal tissue covering the dilated pelvic ileal system, that means probably you cannot deal with this patient in a percutaneous nephrostomy pathway. As opposed to this, in the two examples that we are seeing on screen, you can see some renal parenchyma covering the pelvic ileal system. Here is the situation where you can make a puncture through the parenchyma into the pelvic ileal system. Also, extremely importantly, there is nothing laying between the anterior abdominal wall and the renal parenchyma. If you see bowel gases between the renal parenchyma and the anterior abdominal wall, it can be mechanically pushed aside. Going ahead, there can be another anomalous situation like an horseshoe kidney. Though fluoroscopically, it is extremely straightforward to get an upper calyceal puncture. But if you use an ultrasound, your confidence to puncture an anomalous kidney would be further enhanced, I would say. Here you can clearly see the upper pole was punctured on the left side of the screen, and there was nothing indenting between the parenchyma and the skin. Similarly, situation was seen on the right side. So anomalous kidneys are definitely a situation where ultrasound may score over fluoroscopic punctures. When we are talking about anomalous positioning of kidney, post-transplant situations are also situations where kidneys are placed in an anomalous location. So what is the implication of ultrasound to a surgeon? One is that, is the kidney lighting up well? Is it well vascularized on all poles? If yes, then what is the resistive index? If the resistive index is high and the vascularity is good, it could be a situation where you are dealing with a rejection. Or even in situations like the situation where tacrolimus levels are high and the creatinine is getting high, by doing a simple Doppler and by establishing a raised RI, you can say that the surgical part of the procedure has gone well. Similarly, seeing flow across the anastomosis gives you a lot of confidence and a feedback so as to how you have done the reconstructive work. So that is the importance of doing a Doppler and ultrasound post-transplant. There can be some situations where you'll end up in trouble, like a situation where there is a post-transplant uretrovesical leak. So this is an example of that particular situation where there was a uretrovesical leak. We have done a percutaneous puncture into the pelvic ileal system and done a dye study to establish that there is a leak of urine at the lower end. You'll soon see that there is some leak of urine at the lower end. This leak is also observed as a collection on ultrasound, which can be subsequently aspirated. So here a DJ was passed on a wire and the leak was aspirated using ultrasound. So that is the collection, a needle put into the collection and the urine is aspirated, stent is placed. So in post-transplant situation, it can be extremely helpful. Another situation where ultrasound can be helpful is a lymphocele. So here you can see a lymphocele which is lateral to the kidney. Lymphocele can be very well visualized. A percutaneous puncture can be done and aspiration can be done. This laparoscopic view is to show you the relation of kidney with the lymphocele, exactly mimicking what was seen on the preoperative ultrasound. So that is also quite heartening. And after the drainage of the lymphocele, see the kidney looks expanded and there is nothing compressing. Again, it acts like a second opinion to the surgeon. Another situation where there is a collection post radical prostatectomy. So you want to aspirate this collection, send it for examination to know whether this substance is urine or lymph. So here is sir doing a puncture into that lymphocele and aspiration clearly tells you that this particular fluid is lymph. It was sent for biochemistry and sclerosant in form of betadine was instilled into the cavity. So that is another important use. Now moving ahead, let us talk about transrectal ultrasound and transrectal ultrasound guided biopsy. So that is the setup for a transrectal ultrasound. You decide the number of, the transrectal biopsy. You decide the number of pores that you are going to take. Keep the equal number of bottles ready. Your initial puncture needle basically acts as a needle through which you will give local anesthesia. The biopsy gun is similar to what we just described. It is the Magnum by Bard that we use. The gun is constant and you keep changing the needle. The needle is fixed onto the biopsy gun or the biopsy gun by engaging the two red flanges into the levers that are there. The gun is closed and then it is charged twice so that this particular zone becomes completely red. Then you turn on the trigger from the standby to the fire mode and you're ready to fire. You can see that you have two core lengths, 15 mm and 22 mm. For a truss biopsy, you should choose a 22 mm core length. Now the truss probe is introduced while the convex surface of the probe is towards the prostate. Once you lever your hand down, that means the tip of the probe will go up and you will visualize the right side of the patient because the patient is in left lateral position. Similarly, if you lever the probe up, the tip will go down and you will visualize the left side of the patient. This can be achieved by moving the probe clockwise or counterclockwise. If you move the probe clockwise, then you see the left lobe. If you move it counterclockwise, you see the right lobe. First, scan the prostate. If you want to check the vascularity, the Doppler probe can also be used. The biopsy will be done sequentially as is being taught to us. So this is not a forum to discuss the how you would do biopsy. We'll do a double sextant, of course, and they'll be laterally directed. But what we want to discuss is the importance of ultrasound in achieving the biopsy. So you decide the trajectory after local anesthesia, which is infiltrated, and take the laterally directed biopsy. Again, the core length should be 22 mm, which is very, very important. Something that I want to discuss in terms of technicality and use of the side firing probe is that sometimes you want to go up really anterior and take the anterior zone biopsy. So that time also you have to use ultrasound very, very intelligently. First is you come right up to the apex. How do you know that you are at the apex? You will see the urethra in cross section rather than the prostate. Now your biopsy line should be hitting the upper 1/4 of the prostate in the sagittal section. That is the time you know that you are going to target the anterior zone. It is very, very important to target the anterior zone. And this particular technique has to be used when you don't have the end firing probe. Because if you don't do this, you will end up missing about 25% of the cancer. But if you're lucky enough and have an end firing probe, then you can do the biopsy in this particular way. Technicalities of using an end firing probe are very, very important. If this is the probe, end firing rays will come from here and the needle will come along the probe. When you talk about laterally directed biopsies, if this is the probe, the needle will go at 45 degrees. But if you use the end firing probe and imagine this to be the prostate, it will pierce the prostate from the peripheral zone into the transitional zone and then again into the anterior horn. That means you'll get peripheral zone, transitional zone, and peripheral zone again. So this is an important targeting technique as far as biopsy is concerned to increase the yield of biopsy. So let us talk about all the abscess aspirations in this particular slide. First, we'll talk about truss aspiration. So here you visualize the prostate in cross-sectional as well as sagittal view. You have confirmed by your clinical examination that this patient is likely to have an abscess, and you demonstrate that abscess in the cross-sectional view. Now you clearly see in the sagittal view that this is the area where there is an abscess. Your needle and guide are in line. You puncture, you will get a giveaway. Demonstrate that the needle is into the cavity. Withdraw the hub. Connect a 10 or 20 cc syringe and then aspirate to see if the pus comes out. So here clearly we can see that the pus has come, about 2 cc's of pus was seen into the syringe. All the abscess that are pertinent to a urologist, namely a truss abscess, a prostatic abscess, a psoas abscess, a perinephric abscess, all can be drained using the same method. Again, here we are targeting another abscess cavity. So as you keep on pushing the needle, there will also be a situation where you will lose the window. But once you get a sense of give way, toggle your ultrasound 10 degrees left and right, and you will know whether your needle is inside the cavity or not. So here we are aspirating, and then we'll be able to demonstrate that we got some pus. Transrectal ultrasound also has few other important applications. This is a situation where post-prostatectomy patient had intense LUTS. We did a transrectal ultrasound and we could pick up a migrated clip. And you will be able to see in the cystoscopy later on that there are indeed migrated wet clips. Then individually, all of them were plugged and removed. Transrectal ultrasound can be used for aquablation. I'll show you a video of aquablation using truss at the end of the presentation. Basically, transrectal ultrasound is used to visualize the prostate, and pressurized saline is used to disintegrate the prostate. That is what aquablation is. Coming to intracavitary ultrasound. So this is basically used for bladder. Here, there are three probes or three probe heads that can be used. They have an angle of visualization. The probe that we have put in is a 90-degree probe. There is a 60-degree and 135-degree probe which can be used. 90-degree probe is the most commonly used probe. Like you can see, it is connected to a ultrasound, the long ultrasound bar, which has a connection like a lever lock. You have to introduce this through the resectoscope into the bladder, keep the bladder more than partially distended, complete the lever lock attachment, and this is the scanning probe, which the scanning button, which needs to be pressed. On the left side of the screen, you can see how the tumors will be visualized. And if you keep doing this procedure regularly, you will be able to predict which ones are muscle invasive and which ones are not. Again, to the left side of the screen, you can see that the lever lock has been engaged and the scanning has been started. In the left-sided example, you can see a small growth at the level of 5 o'clock. So that is how you use the intracavitary ultrasound. Coming to transperineal biopsy. So this is a probe which has a long linear array. It has a transperineal biopsy guide. So this portion goes inside the rectum, and then you have the parallel points through which the punctures can be done in the transperineal location. Two grids are separated by a distance of about a centimeter, and there is a dot in between. That means effectively you can take biopsy at every 5 millimeters. Advantage is that when you take a transperineal biopsy, you get a complete core. That means you will get the anterior zone, again the transitional zone and the peripheral zone. So the ability to pick up the anterior zones is very, very high. So this is the transperineal grid, which is attached to a special probe, which can help you take transperineal biopsy. Intraoperative drop-down probe. It is for all the people who are doing partial nephrectomies, laparoscopic or robotic. This is a drop-down probe that all of us need to discuss. It is a small 3 to 4 centimeters probe, which can be held by a robotic instrument, and the kidney can be scanned intraoperatively. So this is the drop-down probe, and it has a grip. The grip can be held by a robotic instrument. The distance markings can be seen along the length of the probe, and the tumor can be measured from all the sides. So if you look at this particular example, so this is the use of the probe. We are on to the tumor. The tumor is visible in a picture-in-picture format. We can keep marking the tumor throughout its circumference and then start cutting. So the probe can be moved on the kidney in two ways. One is craniocaudal and other is mediolateral. And both the movements will help you define the define the tumor margins. Then you could subsequently score the tumor, and after clamping, you can cut the tumor as well. This is a very, very important application of ultrasound, which is an ultrasound guided block. My anesthetist friends do this, and this is a audio video presentation. So I request you all to pay attention.
Ultrasound guided obturator nerve block is safe and precise. The patient is positioned in a frog-leg position and the groin is scanned. From lateral to medial, femoral artery and pectineus muscle can be visualized. Thereafter, adductor group of muscles are seen, longus, brevis and magnus namely. Between the longus and brevis is the anterior division of obturator nerve, and between the brevis and magnus is the posterior division. Under ultrasound guidance, the plane between longus and magnus is reached and the drug is infiltrated. The drug tracks along the sheath of the superficial branch of obturator nerve and reaches the pelvis. Thereafter, another puncture is made to reach the plane between the brevis and the magnus, and similarly the drug is infiltrated. This drug tracks along the sheath into the pelvis along the main trunk of the obturator nerve, thereby achieving an obturator block. Bupivacaine and ropivacaine are the commonly used drugs to achieve this nerve block.
So that is how you give an obturator block. Whenever obturator block works, it really works like magic. The last segment of my discussion is something which is very, very close to my heart. It is ultrasound for vascular access. And I can share a personal experience. Ever since I started doing my own Doppler, the fistula success rates improved at least by 10%. So you start to scan the hand in the cross-sectional angle, visualize the radial artery going up to the brachial artery, and then you can see the brachial artery along with the vena comitans. Here again, you see the ulnar artery and then keep tracing it to the brachial artery, where you can see the vena comitans again. Do the same thing in a longitudinal orientation. Here you will be able to better see the cross-sectional diameter of the artery, vessel wall condition. Also, the flow in the artery will be well visualized, and the flow pattern, that is the artery having a normal triphasic pattern, will also be very well visualized. Go up to the brachial artery and do the same thing. So you see the vessel one, the vessel wall condition, how is the flow, is it slightly compressible? And then you can confirm that as far as the artery is concerned, you can have a good vascular access. So that is the brachial artery. You see that in longitudinal direction now. We try to see it in the longitudinal direction. And once we see it in the longitudinal direction, we will try to see the flow in the artery. So there we are, measuring the cross section and the flow. This is how you will be able to map the arterial tree of the upper limb. Once you have done that, move your attention towards the vein and do a vascular mapping for the vein. So that is the cephalic vein in forearm. You keep tracing the cephalic vein till you go to the level of the elbow, where the cephalic vein will basically meet, will either become the cephalic vein in arm or or join the basilic vein. So there is the vein. Any structure which has thin walls is compressible and pliable, has a respiratory variation, has a monophasic flow, is basically a vein. So that is the cephalic vein in arm now. And after this, we should see the basilic vein in arm. So that is the cephalic vein in arm. We say that that is a cephalic vein because distance from the skin is less, whereas the basilic vein is a really deep structure. Again, we see the monophasic flow, which tells us that this is a venous structure, not an arterial structure. For anybody who's starting out, these things may be important to know. That a structure which is collapsible, has thin walls, has monophasic flow, has respiratory variation, is a vein. There you see a deep structure, again venous in configuration, but there is a lot of subcutaneous tissue above. Therefore, that is the basilic vein. So this can be used for basilic transposition. Another important thing when we do access work is to see if the artery is really worth doing a fistula. So you would do Allen's test, etc., etc. But this is a quick test which helps us know that whether this artery actually is capable of lot of resistance. So you clench the fist, and suddenly the entire flow will become exaggerated. And once you remove your clenched fist, there will be a monophasic response. So here is the clenched fist. You can see the triphasic flow. And once you remove the clenched fist, then you see a hyperemia. So that is what is an hyperemia response. Now, sir, I have talked about whatever I do with ultrasound. One example I wanted to cite where ultrasound has actually saved my day. So this is a patient. I thought I am going to do his clot evacuation. So this is a situation where I thought this patient had a swelling, and I thought I will do his clot evacuation. And the moment I put the probe, I can see the pseudo aneurysm right here. So it just saved me of a very, very difficult situation. So ultrasound can always be your friend. Another thing that I want to talk about is once you have made a fistula, it can help you judge if this fistula is doing well or not. It can help you measure the diameter of the fistula, diameter of the outflow tract, distance between the skin and the outflow tract. This all, if they corroborate to the rule of 6, then your fistula is doing fine. So with the note that ultrasound actually on occasion helps you save the day, I would like to give you a take-home message, which I learned from Dr. Desai, is Sir always says that we all need a second opinion in life, and ultrasound is undoubtedly the most reliable second opinion. Thank you for a patient listening.
Thank you very much. That is very crisp. 45 to 50 minutes. You have spoken very slowly, crisp, and you covered all more useful for the beginners, and also for those who wanted to start any particular technique. So now I will go on quick fire without explanation, question answers. First, most important, entire India will be looking at is if you do not have BK ultrasound. For years, I have used Philips ultrasound, no conflicts of interest, GE, Philips. If you use ultrasound, it is no problem. You can see liver, you can see kidney, you can see muscles anterabdominal. But the moment you keep the needle to puncture the dilated system, which is not very large dilated system, moderate hydronephrosis, whether to put the needle from the upper part of the convex curve, lateral part of the convex curve, posterior to the convex probe is the first question. So in any direction, if the trajectory is not there, my question is, in any direction, if the trajectory is not there, is there any way you can help us? Now I have BK, that's a different issue. BK is relatively expensive. In private practice, everybody has an ultrasound in his OPD with some diagnostic center or in the hospital. They wanted to ship with PNDT permission and do the puncture. Have you tried or you have not tried? Because you are directly on bench car. So I am asking whether you have driven the Maruti car or not.
Yes, I have driven. In fact, sir, the first puncture that I did, or first drainage of an abscess that I did it in one of the very, very peripheral filters, one of the small private hospital in Ulhasnagar when I was doing private practice in Bombay. So
Very
that
good.
is my first experience with ultrasound. So what you have to do is you have to put the probe there. Put the probe there. If you don't have a guide, that means you are not usually not using this particular probe routinely. So what you do is put the probe and now with an stiff instrument, jiggle the skin. First do it at a lower border, then do it at the middle of the probe. Say probe is 3 centimeters, you do it at around 1.5 centimeters. You see where you get the impression of the jiggling onto the structure that you are targeting. If you get this jiggling impression, that means there is a high chance that you will get into the target. Do it at the lower pole, do it at the center, anteriorly as well as posteriorly. So amongst these three areas, there will be a favorable area. Now, because you are not using the trajectory that, or the software is not guiding you with a trajectory, that means you have to select arbitrary points and see whether your needle can go into the target area. And to ensure that whether your needle is going into the target area or not, you take a stiff metal instrument, jiggle it on the skin. If the impression is going to the target area, that means you will be able to go to the target area. This is not foolproof, but you can try this.
My second question, have you used any in fact it's a question from Madhav Tiwari, have you used any ecogenic needle in your center?
Yes. So there are ecotip needles. In fact, the needles that you saw in the video demonstration also have some ecotip, but there are specific ecotip needles are available. At the distal third of the tip, it is just roughed up. The metal is roughed up so that it gives you acoustic shadow. So they are helpful, but your routine metal needle will also, it is acoustic. So it will throw an
Not
acoustic
necessary
shadow.
that much. My third question, you have shown barred the biopsy gun. We use disposable barred gun. Disposable barred gun comes around 3,000 rupees. Do you think that this barred fixed gun, except changing the needle, will it come? I mean, for quite a large number of cases, it is actually very sturdy, and any number of times it can be used.
Yes. So it is a relatively costly device. Costs
How
about
much roughly
1.5
it will
lakh,
cost to your knowledge? No,
1.5 lakh rupees.
yeah.
1.5 lakh rupees.
So
And
around
then the needle,
3,000 rupees, the disposable gun will come normally. If you see,
yes,
that is we are using since long time. Through any probe, it will go. Only thing is that the 15 mm this length cannot be measured in that. It is a disposable. It's how much depth you go inside. That much length only it will come. Since long time I am doing prostate biopsy with the end on fire. Now I started doing side firing also. That's why I'm asking that. We approximately go through the prostatic fossa like the renal capsule dipping. You said we dip at the capsule and we see if the periphery is less, we go back and then fire. If the periphery is more, we pinch and then fire. So
yes,
here in your gun, you said that 22 mm is the minimum required.
is the
Will you
maximum.
maximum? So in apex, it cannot be possible, na 22 mm.
Yes, sir. So then you decide whether you want to fire from a distance, or if you think you need to take a smaller core, then you shift to 15 mm. Usually you are able to do with 22 mm in prostate, but
22.
depending upon what you are planning, you can change.
Yeah. One small question, even though I know the answer, for the audience from your angle, I wanted to know. See, ultrasound, as Mahesh Desai sir said, not only the second opinion, it is like opening the abdomen and seeing in a three-dimensional view. It is not possible other than MRI, nowhere it is possible, cheapest mission. So how do you identify anterior calyx and posterior calyx in ultrasound?
So, sir, if you start scanning the kidney like you would do from the paraspinal area towards the posterior axillary line, the first structure, water-filled structure that you see in the kidney is the posterior calyx.
Posterior.
And as you keep going anteriorly, you will see other structures which are anterior
So
calyx.
the probe will see only perpendicular point at that level of the skin.
Yes,
If
yes,
you are close to the spine, you are posterior. You are close to the umbilicus, you are anterior.
correct.
Same. So there is no confusion. It's a purely virtual where you just go from posterior to anterior. The more anterior dilated calyx is seen, you can puncture like what we do in supine. Whereas in prone, we go more paraspinal. See the maximum dilated medial calyx, that will be this thing.
Yes.
And now, have you ever tried Doppler for puncturing the kidney before you puncture, or it is not necessary? Same thing, have you done Doppler any use in the prostate biopsy where you can identify the lateral vessels, pelvic so-called neurovascular pedicle can be identified before firing? Especially this is more useful in the end firing, may not be very useful in the side firing. What is your comment on using, because that is the one area in routinely, will you see any renal vessels in biopsy as well as the PCN?
The truth be told, it is not done in every case.
Yes.
But where you are thinking that you might land up in problem, like there is a situation that a particular patient has had history of pseudoaneurysm, PCNL or something attempted outside where he bled torrentially. So these are the situations where you want to put on the Doppler. Where like there is the anecdotal case that has happened at MPUH that PCNL was attempted outside. There was a torrential bleed, and then the patient referred to us. We did an ultrasound. And actually there was no stone visualized. It was only at the calyx that you could see some calcification, and around that lot of vessels. So basically, again, a repeat CT angio was done, and it was found out that these were calcified vessels rather than stone. So that is one occasion that, in some special situations only, you would use Doppler. Usually, you will
Otherwise,
not
you
use
are
it in
going
every
from
case.
the periphery, you are
Yes.
going most periphery, you are going most superficial part of the calyx. There is no point arise that you are seeing the vessels at all, because your needle will be seen unless you go more medially, which you should not go. Next, my next question is, how many of cases in Nadiad MPUH you use ultrasound for puncture? 0, 5, 10%, or only for academic purpose, or only absolute indication like upper ureteric stone where contrast does not go, ureteric avulsion, ureteric. When will you use ultrasound in your theater, honestly, for stone work?
So for stone work, ultrasound is used daily for almost everything. But like there are two parallel cases going on, so maybe one surgeon will not use ultrasound.
That means you tell you, if you have 10 ultrasounds, you have every time ultrasound available, you like to have one picture of ultrasound before you puncture.
100%, sir. 100%.
100%. That is a very good answer. I expected also, and you told truthfully that I am feeling now, because I kept the ultrasound in the theater with permission. It is so user friendly for various reasons. Where is the upper pole? Where is the lower pole? Where, how much mal rotated? How much dilatation? Quick information it will give. Whether you puncture every time with a guide or not, different issue, but you will not go grossly wrong in an abnormal direction, especially in post-operative cases. Do you agree with that?
Sir, that is a very good thought. I agree to it 110%. That even if you cannot puncture a particular case with ultrasound, still it is worthwhile doing an ultrasound, screening ultrasound, because you never know. It is a difficult case. Therefore, you are not able to get access with ultrasound also. A case which is difficult is going to be difficult with ultrasound also, fluoro
Yeah,
also. But
please.
at least if you are going to make some adventurous punctures, you at least know what is coming in between,
Yes,
which is
yes, yes. If you
extremely valuable.
repeatedly see, you can identify the muscles so well. In matter of 3 months, we are able to identify external oblique, internal oblique, transverse abdominis, and you often easily identify the colon with a horizontal echogenic like that. It will help if you do daily. What do you say?
Yes, sir.
Right. If you have the mission, you use it daily for any PCNL. Next question. One area you have not covered, unfortunately or fortunately, it is the most common ultrasound I do every day. Doppler ultrasound scrotum. I do every day myself because the from beginning we used to do ultrasound Doppler ourselves. What is your opinion in varicocele? I want to ask a theory question. There are lot of controversy. Quick, your opinion. No book can answer this. If you palpate the varicose veins, it is 100% sure that it is clinically significant, especially dilated big veins. In ultrasound, when you are doing Doppler, I remember that 0.15, 0.3 marks. If anything 0.3 comes with Valsalva maneuver, I feel that there is some amount of varicocele. If it is more than 0.4 something like that centimeters, it is obviously varicocele. A big bunch of veins if seen from the moment you keep the probe, high suspicion of the varicocele. So what is your objective interpretation? Quickly I wanted to know from the high frequency probe which you use.
So, sir, I would, if I do a scrotal ultrasound, I would use the same guidelines, less than 1.5 millimeters, 1.5 to 3 millimeters, 3 to 4 millimeters, and more than 4 millimeters dilated veins. Again, so these are my criteria. Again, truth be told, I do not do scrotal ultrasounds for varicose veins. Only because we have been all at MPUH trained by, and earlier I was in Bombay trained by Rupin Shah sir, who does the Dopplers with a handheld Doppler. Therefore, we are just following what he has taught us.
That's
So
why I asked this question. So you don't do routine color Doppler, you use power Doppler.
The handheld Doppler, the small
Handheld
portable
Doppler.
handheld. Yes.
Handheld
So
Doppler.
we put it, and based on the sound, we gauge what is the reflux. So that is how.
That's why.
Because sir taught us that way, therefore we are doing it.
Power Doppler, which company, any routine company will give, or it is a separate probe, no?
So this is a small machine that comes for about 10,000 rupees. A small, it comes like a transistor. It is there.
Yeah. So do you think is useful in scrotum?
Yes.
Also, lot of people use in peripheral vascular disease, particularly TI. What is that? The smokers who used to get exam, na, the case. Lower lip vessels they assess. Vascular surgeons keep them in their pocket.
Yes, sir. So there, I would do testicular ultrasound routinely myself. Is all acute scrotum. All acute scrotums I will do an ultrasound myself. Though because acute scrotum is a relatively rarer clinical entity that we see in clinical practice, before making a decision, I will always consult the radiologist. He's just next door. His office and my office are just next door. So I'll just do it and then I'll go to him.
Few last couple of questions. When do you think in ultrasound abdomen, both kidney as well as the ectopic kidney, you feel ultrasound is really difficult to interpret? What are the clinical conditions where you feel that it is not helping? That means as a transducer to the to the, like in obesity, any other conditions where ultrasound, for example, I wanted to ask in that way, you inject local anesthesia too much, the ultrasound image may go sometimes. Will it go or will it does not go?
So when you are doing biopsy for small prostates, be very, very careful. If you flush and put in 10 cc of lignocaine, then your trus biopsy is finished. So
only that solution will be seen, prostate will not be seen. That is what I am asking. Same in the kidney reason in children. When I inject some pyonephrosis local, I get confused with the PCS and it will be only 1 centimeter below.
Yes.
So if you inject 5 ml, entire thing that looks like PCS.
Yes. So you should be very careful there. Another situation is in an ectopic kidney, which is completely has an anterior pelvis. It is very difficult and confusing. So what happens is the anterior pelvis is the kidney is posteriorly, the pelvis is anterior,
Yes,
and the
yes,
bowel is lying next to it. So
yes,
you cannot make up your mind whether this is bowel,
yes.
muscle, or
Other
fluid containing
pieces.
something. Yes. So that is another situation where you must always rely on your preoperative imaging also. If the pelvis is completely anterior in an ectopic kidney or an anomalous kidney, then at least if the kidney is lower down or in pelvis, your percutaneous access is not a good option.
Yeah. Last question. When you try to do the puncture in a non-dilated system with ultrasound, it is difficult
Yes.
because you need to see fluid filled cavity to puncture. Do you think the ureteric catheter nowadays, I am using flexible scope, identify the calyx intraluminal, inject the water in that, move that, ultrasound can easily pick up that movement, fix it in the perpendicular, go on it in a non-dilated system. In non-dilated system, what is your tip and trick for the ultrasound guided puncture? Your accuracy should be maximum.
Hmm.
And if the stone is large one, do you think any role of ultrasound in that first of all? No. Non-dilated system, is there any role of ultrasound?
So non-dilated system, you one situation is use a ureteric catheter, dilate and puncture. Ultrasound will still help you. Secondly, if it is a stone-filled calyx, you will be able to visualize that, and then you can go like you in fluoro you go stone guided. In ultrasound also you can go stone guided. Especially lower calyx is one situation where
Yeah.
you put. Sir, there are situations where the system is non-dilated and you don't have an option only. If the ureter is leaking somewhere, then ultrasound is your best
This is
bet.
my last question. So this is my last question. You came to yourself that point. My favorite question, in any peripheral center, if you avulse the ureter in a non-dilated upper ureteric stone, your system will never be distended. Hurriedly, local radiologist without experience, if he punctures multiple times, he can lead to large hematoma and unsuccessful PCN. So in that case, wait for a day or two, let the system fill up, even if it is urinoma, refer to a higher center where experienced person after reading the CT and ultrasound do the puncture. This is my last question. So in such situations, if the case is referred to you, avulsion, immediately after 2 hours the case is with you, non-dilated system. Doing PCN is lifeline. Doing PCN is lifeline.
Yes.
How will you do it? Do you give Lasix? Do you give IV fluids? Do you take expert and is there any method you can make some visualization of the PCS?
So, sir, it should be done by the best possible person, or at
Yes.
least the best possible team is there.
Yeah.
So, you should gauge for yourself whether you are capable of doing this puncture or not. Every surgeon knows his limitations and what he can. So, just gauge by doing an ultrasound what you can achieve in this particular patient.
Yes.
That is point number one. Get the maximum help. That is point number two. Third is give this patient adequate amount of fluid and Lasix to see at least 5-7 mm of dilatation.
Yes. 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 Yes.
Keep a possibility of IV contrast also ready.
Yeah.
So with all this preparation and IV contrast, possibly you may need methylene blue sometimes. You never know. So
Yes.
keep a proper provision for IV methylene blue also ready. So with this, always do these punctures under general anesthesia. These are not the punctures that you can do under local
Yes. Yes.
anesthesia.
Yes. 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 Yes.
Use the position that makes you most comfortable. If you are
Yes.
a prone surgeon, don't do it in supine or vice versa.
Yes. Yes.
Then I am a prone surgeon, so I would definitely do these in prone position, absolutely under general anesthesia. Absolutely under general anesthesia.
Completely system should be under your control, not
Yes.
without much respiration. You should have a clear beam going towards that calyx. Even smallest the water that you can see through the ultrasound, you hit it with accuracy is what an answer. Excellent. I must thank you. It's one of the best presentations on ultrasound I heard. It also just like it was like a book rolling. You went very smoothly and you did not go deep into any part of it. It's a very big subject, and you made it crisp. Definitely, what I wanted, I got it. 100% I got for my pure talk. That is what I mean to say. And how to do a PowerPoint presentation also in the future we will do. It is one of the good, whatever the task I have given, you have done it. 2 3 people we wanted to make like moderators, and for all the juniors, how many slides should be there, how much time is given, how much what is the number of words, number of lines one should have. This also I will take your help. You are crisp in your presentation today. Thank you very much for all the videos. Very useful. Very useful.
Thank you, sir. Thank you for the opportunity, and it is an appropriate forum to thank all my teachers. I have learned all my ultrasound skills from Mahesh Desai sir and Sabnis sir and Arvind sir, and this is an appropriate time that I really thank them, and I'm indebted to them for life, that whatever they have taught me, I've been able to present. Sir, a word of compliment to you. The way you have put up this program, which initially a person may see, may think otherwise, but now since that it has gone to 8,000 people and beyond a year, everybody can see your selfless motive into bringing up this program, and just for the cause of learning, this program has been set up. So many congratulations to you. I also take this opportunity to thank your team and Mr. Rajendran, who's always been very helpful. Thank you very much, sir.
Thank you. Great.